and as folks are logging in, want to welcome everyone again to Cancer Center Grand Rounds. The theme for today is an important one, namely global oncology. And obviously, our attention has been particularly drawn this year to the public health crisis that's the COVID pandemic. But as many know, really over the past several years, the National Cancer Institute, the World Health Organization, the American Society of Clinical Oncology, AACR, among others, have really increasingly wanted us to emphasize elements of our work on the global needs and global oncology. And so it's really my privilege to introduce the introducer for today's session. I've had the privilege actually of working with Donna Spiegelman for many decades, I guess. Donna, as you know, is the Susan Dwight Bliss Professor of Biostatistics, the Director for the Center of Methods and Implementation and Prevention Science, the Director of the Interdisciplinary Research Methods Core for the Center for Interdisciplinary Research on AIDS, and particularly relevant to today, the Assistant Cancer Center Director for Global Oncology. Donna has legions of accomplishments, but they include her productive work in global oncology. I'll turn it over to Donna to introduce today's speaker.
Yeah, thanks so much, Charlie. And indeed, it's been a pleasure working with you both at Harvard and now here at Yale. And thank you so much for supporting my work and interests through connecting me to the Cancer Center and the Global Oncology Program. This is our second of this academic year's Yale Cancer Center Grand Rounds on global oncology. Our first one we had in person, this pre-COVID, Dr. Jorge Salmeron from UNAM, the National University, Autonomous University of Mexico City, and the National Institute of Health of Mexico, who has been doing work for many, many years on cervical cancer prevention and screening. And we're continuing to work with him along with colleagues in Nepal. Today, we're very pleased to get a very big picture type of view, which I'm really excited about, by having our guest Doug Pyle, who unfortunately we can't wine and dine except in our imaginations. But we're so happy to have him today for this Zoom seminar. He's the Vice President of International Affairs at the American Society of Clinical Oncology, well known as ASCO, and he joins us today for a discussion centered around global oncology. He graduated with his MBA from the Yale School of Management. We also found out this morning at a very early morning call he was so kind to have with myself, Melinda Irwin, and Marcela Nunes-Smith, also leading various related efforts at the Yale Cancer Center, that he's wife to her pediatric residency here at Yale. So New Haven and Yale is something he's part of our community as well. And after Yale School of Management, he went on to become Director of Business Solutions, International Services for the American Red Cross, and then joined ASCO in 2007. He's responsible for directing its international programs and advising the Society on the needs and interests of its international members and constituents. He has more than 25 years of experience in international affairs in the public, nonprofit, and corporate sectors. Earlier in his career, he was the Vice President and Chief Operating Officer for the Center for International Rehabilitation, the Manager for Strategic Planning and Business Development for the U.S. subsidiary of ESI, and administered technical assistance projects funded by the U.S. Agency for International Development, USAID. Today's talk is co-sponsored by the Yale School of Public Health Center for Methods and Implementation and Prevention Science, CMIPS, which I lead, and I'm very excited to turn things over to Doug to let the audience know you can write questions and comments in the chat box. I'm not sure if it's possible to actually activate so you can talk, but Charlie and I are both monitoring the chat box, and we welcome your comments, and we will potentially check in with Doug at suitable times to inject your questions and comments, and presumably there'll be some time at the end as well. So thank you very much, Doug. We're looking forward to your talk.
No, this is great. I've been really looking forward to this, and thanks so much for the invitation. I'm delighted to talk on, yeah, I agree, an important topic. Just real quick, I don't know if you can see, but I'm channeling, it's blocked out. I'm channeling my New Haven by having my 1990s era doodle mug here. So your first CME question is, how many of you know what the Yankee Doodle Diner was in New Haven, which I guess has since closed. I had to look that up. But delighted to be here and dive right in. So Donna and Charlie, let me know what kind of questions are coming up, and also let me know how I'm doing on timing. I got a lot of stuff to go through. I want to make sure that we have plenty of time for discussion, because I want to hear what the Yale community thinks about some of these themes that we're going to talk about.
Okay.
So here are my disclosure. I'm sorry?
I said, okay, I'll keep an eye on the time for you, Doug.
Great, thank you. So no conflicts to disclose. So here are my learning objectives. I'm going to be talking about the overall global cancer trends, mainly in the context of the rise of non-communicable diseases, or NCDs, primarily in low and middle income countries. I'm going to talk about ASCO's overall strategy and programs to help address these trends. Then I'm going to get into the impact of the pandemic on ASCO's response, and what are some of the silver linings, some of the opportunities for innovation that we discovered during this time. And then looking beyond the pandemic, looking at reviewing ASCO's position on the future of global oncology as an academic discipline, why that's important, and ASCO's role in supporting global oncology. So first, starting with the global picture. Here, so I'd like to start actually with the Global Burden of Disease study, a landmark study that was published in The Lancet in 2012, that really documented this global health shift from child and maternal health and infectious diseases, which is, I think, how most people think of global health, to non-communicable diseases, or NCDs, including cancer. And so you can see this shift here, just kind of comparing these two columns, 1990 and 2010, and looking at the main risk factors for disease in 2010. These are the top risk factors, and all of them relate to NCDs, and most of them relate to cancer. So it was in this context that ASCO came together with a host of organizations around the world, not only in cancer, but we partnered with our friends at cardiology and across other societies to really press for the importance of a UN high-level meeting on NCDs. So why is this important? So the UN at the time had only held one other high-level meeting on a health topic, and that was during the AIDS crisis. So that gives you a sense of the importance of these high-level meetings. And in fact, the meeting was held in 2011. The world came together, and the reason I'm pointing this out is because this was a transformative moment when cancer was really recognized as a global health priority. It's not only a disease of rich countries, but really seen as a global health issue, along with other diseases included in the NCD kind of framework. And the world came together and it set a world target to reduce overall NCD mortality rates by 25% by 2025. So it's now 2020, and how are we doing? Well, unfortunately, the gains that we saw early on in NCD mortality rates reduction are slowing. So up till 2010, the reduction was about 1.6% per year. And that gave us optimism that 25% was achievable. Since then, it has been slowed to about a little more than 1%. Why is that? Well, this could be a topic for a whole nother talk, but the factors are complex. One of them, of course, is that this NCD burden is hitting countries that in fact are in transition. So they're facing infectious diseases, and they have a health system that's calibrated to address infectious diseases, while at the same time they need to recalibrate their health system to address the NCDs. But one other dynamic that I just want to flag that is interesting is there is a shift in the risk factor trend. So this is, again, WHO data. And when we look at some of the risk factors for NCDs, so you see that alcohol consumption has ticked up a little bit, not too dramatic, but has risen a bit. While it appears that tobacco use is declining, that rate of decline is starting to slow, which is concerning. And then obesity. You know, when we talk about cancer and other NCDs, we don't talk very often about obesity, but this is a diet is changing, and this is a growing risk factor. And you can see this not only globally, but in regions that you may not necessarily think of, such as the Africa region. So these are shifts in risk factors that are driving this change. Taken together, cancer, of course, along with cardiovascular diseases, are the #1 killer in the world, and it's projected to grow quite dramatically. And most of this growth is going to be hitting low and middle income countries. So both in terms of new cases of cancer and cancer deaths, the bulk of that growth is going to be in the countries that can least afford it, and where it's going to be most challenging. Now we can drill into specific diseases here. You can see that the incidence rates of specific cancer diseases are higher in high-income countries than low-income countries. I would caution a bit on this data. So a couple of issues. One, of course, is the pathology capacity in low-income countries is a challenge. And so the actual, the true incidence rate in low-income countries will likely be higher. But then, and also in low-income countries, the data and cancer registries is a major limitation. So you have to take the data with a grain of salt. But looking at the mortality rates, you can see that in many of the cancer types, the mortality rate is the same or higher than in the high-income countries. And then just kind of looking down at cervical cancer, now we want to take some time here to pause with cervical cancer. Of course, the incidence rate is much higher for cervical cancer in low-income countries, and the mortality rate is significantly higher. And when we look at sort of a map, you can see that in sub-Saharan Africa, this is a mortality data, by the way, mortality rates from the GloboCan database, IARC GloboCan database 2018. And so you can see in sub-Saharan African countries and other low-income countries around the world, the rates are quite high. So it's in this context, actually, that some of you may know, the Director General of the WHO has declared a plan for the elimination of cervical cancer. The World Health Assembly in August approved a plan for the elimination of cervical cancer. And actually, just before this call, I was on a call with PAHO, the Pan American Health Organization, to lay out the plan for elimination of cervical cancer in the Latin American region. Now, this is going to be obviously a long time to achieve when you have a vaccination campaign, but an active area of focus for the WHO and for the global community. Stepping back again, so clearly outcomes in cancer is highly correlated to income. The bottom axis there is the segments of countries, so the low-income countries, lower middle-income countries, and so forth. And on the left axis, the ratio of mortality to incidence. And so clearly, more resources in different countries across a range of cancer types affects the outcomes in those countries. So when we talk about resources, let's drill into a little more granular detail. And this, we often talk about access to the highest priced drugs in low-income countries, but really these are fundamental aspects of cancer care. Really, the building blocks that are limited in the lower income countries. So surgical facilities, access to key drugs such as essential drugs like tamoxifen, access to palliative care, oral morphine, and the percentage of out-of-pocket health expenditure that the individual faces. I actually think so that it's about 50% out-of-pocket in low-income countries and lower middle-income countries. I might actually, my sense is, I don't have data to back this up, my sense is that actually understates that when you factor in the cost of transportation to get to a facility, the expense in many of these countries, individuals are going to traditional healers as a first course, so they're spending money on other approaches, and these expenses are obviously catastrophic for any individual in these countries seeking any kind of cancer treatment. Not on this slide, but equally, if not more critical, is pathology capacity, access to pathology and laboratory and diagnostics, which is, as you all know, is a key part of the cancer care process and a key factor in outcomes. If you can diagnose it earlier on and get a correct diagnosis, the outcomes, of course, are much better. Access to radiotherapy, another issue. So this is analysis by the International Atomic Energy Agency. You can see again, countries in sub-Saharan Africa that have no radiotherapy machines access whatsoever. This data is a little bit dated, so this is 2010, but really the picture has not changed dramatically since then. It gives you a sense again of where some of those disparities are. And then in terms of human resources, so there isn't existing a comprehensive, quantifiable, comprehensive analysis of the global oncology workforce. This is one of the better studies that I've seen. This was published in ASCO's JCO Global Oncology Journal. So this is not the JCO, but the sister journal to the JCO is focused on global oncology. So Dr. Adju and colleagues looked at data around the world, different data sources, varying definitions of what an oncologist is. So again, you need to sort of take the findings with some caution, but they arrive at a ratio of new cancer cases per oncologist, and just gives you sort of a benchmark, a sense of what the ratios are. So for example, in the United States, 133 new cases of cancer per oncologist. Ethiopia, 10,000 new cases of cancer per oncologist. And as some of you may know, the Ethiopian government has actually launched a multi-year program to significantly expand its oncology workforce and to extend services beyond the capital city to other centers across the country. But it gives you a sense of the magnitude of the issue. So with that as the kind of global picture, I'll now sort of transition to what ASCO is doing in this regard. So just a primer, if you will, on ASCO. It is more than just kind of 4 days in Chicago in June. It's actually quite vibrant oncology society. So our main programs, the annual meeting, we have thematic symposia that some of you may be familiar with. Our journals, cancer.net is our patient information portal. Conquer Cancer is our foundation. And CancerLink is, and I hope there aren't any questions about CancerLink because I'll rapidly get on my depth, but it is our big data platform that is drawing information from EHRs currently in the United States to analyze overall patient care trends and insights. So this is the ASCO strategic plan. I'm not going to go through it in detail, but you'll see the 4 goals kind of running through the middle of the slide there. And on the right-hand side, you'll see making a global impact is not front and center, but a main component of the ASCO strategic plan. And I just think that this really demonstrates the seriousness that ASCO takes with respect to its global profile, its responsibility to its members and its constituents, and its commitment to having a global impact. Because ASCO is a global organization, so half of our meeting attendance is international. Almost exactly a third of our membership is international. Our journals, the Journal of Clinical Oncology, and as I mentioned, the JCO Global Oncology, are read around the world and in effect practice around the world. So with that kind of global commitment and profile, what is ASCO's international strategy to address some of these issues? Well, there's three parts to this strategy. I'll go through it briefly and happy to talk more about it in the Q&A. But there are three components that intersect with each other. So first is leadership development. As a member society, of course, we're focused on engaging our members, and it's really a global health truism, if you will, that if you're going to have an impact and change practice, you need to engage agents of change agents who can incorporate and lead those programs for you. So the leadership development is a key piece. Then we work with those leaders to implement access to quality of care programs, which I'll get into. And then underlying all this activity is research. So we have a sense today of how we can improve access to care, but we always need to be searching for those better solutions and understanding the evidence base and going where the evidence takes us. And the only way, as you all know, to do that is through research. So just really briefly, I'll go through some of these programs. So in terms of leadership, we engage with oncology leaders around the world through, we have our International Affairs Committee, which is a global body. And then more recently, we've started creating regional councils. So our first one here is the Asia Pacific Regional Council. And these councils are members who will help ASCO really deepen our engagement in specific regions of the world, understand what are the challenges, what are the opportunities, and ways that we can engage the oncology community in each of these regions. So those are current leaders, but then we also have to develop the next generation of oncology leaders. Some of you may be familiar with our IDEA program. I know many Yale faculty have been IDEA mentors. Pictured here, as you can see, Yale's own Dr. Anis Chagpar and her mentee, Mercy Isiche from Nigeria. We also have the virtual mentoring program. So these programs identify young emerging oncology leaders, primarily in low and middle income countries, mentor them, bring them into the ASCO fold. And then, as I'll mention more later on, we then work with these leaders and engage them in ASCO programs and help us to implement programs in countries around the world. We also have a leadership development program, which also Anis was one of the first participants in, and actually how Anis and I first met each other. And we have international participation in this leadership development program. So we work then with these leaders to improve the quality of care delivered in their countries. We do this through a number of modalities. First is training. So we do in-person training back when we could do that, and hopefully we'll be able to resume that through ASCO international courses. So our courses are focused on palliative care, multidisciplinary care, cancer prevention, and clinical trials. Here you have another picture of Anis. I promise this is my last picture of Anis. But doing a training course for us, I believe, in the Philippines. And then online training through our e-learning platform and other online mechanisms that we have that I'll get into. Now, ASCO, of course, has guidelines. So we have the standard ASCO guidelines, and then we also have resource stratified guidelines. So those of you who are not familiar with the concept, basically it goes back to the evidence base and says, well, if a certain treatment modality is not available, what does the evidence say that is the next best, and then the next best. And so it enables you to have the best standard of care in different practice settings, still based on the available evidence. So we're incorporating these guidelines into our training. We're also using increasingly internationally quality measures. Some of you may be familiar with ASCO's COPI program, the Quality Oncology Practice Initiative. This takes data from de-identified, anonymized data from charts and compares it against established evidence-based quality measures and produces a report card back to the practice on how they're doing on their quality. And more we're doing this internationally to really assess the quality of care and help practices improve the quality of care that's being delivered internationally. And then finally, sites. So increasingly, we are performing these programs at specific sites where ASCO has a multi-year sort of commitment, twinning relationship, if you will, with hospitals through our International Cancer Corps program. So we're active in Nepal and Vietnam and Honduras, Bhutan, Uganda, working with specific hospitals to enhance their cancer care capacity. And then through a program started by UICC, the City Cancer Challenge, where we're taking that same kind of long-term collaborative model and applying it to cities. So we're working with colleagues in Cali, Colombia, Asuncion, Paraguay, Kumasi in Ghana, and Yangon in Myanmar, and we'll be expanding that. So kind of a drill down here. So case example, Cancer Corps site in Honduras. So we're working at the Hospital Escuela and Hospital San Felipe. This is one of our first programs, started in 2010. We've had about 100 volunteers to date travel to Honduras and work with their colleagues there. The focus there is on GynOnc, safe administration of chemotherapy, multidisciplinary care, and palliative care. We've done this again by working with some past IDEA recipients in Honduras, organizing international courses, doing virtual tumor boards. And more recently, I mentioned the pathology challenges. More recently, working with the College of American Pathologists and pathologists in Honduras, as well as the oncology community, to develop pathology capacity and support their efforts in that regard. And now they've started collecting data and publishing their data. Again, this is the JCO Global Oncology. And all of this, as I mentioned, needs to be informed by research. So when we talk about research, there are some key components, as you know, but just to highlight them, you need to be training the investigators in these resource-limited settings to conduct the research, because the research needs to be done in these settings. That's how you're going to move the needle forward. So ASCO is doing clinical trials workshops in low and middle income countries, training investigators on the best practices for the conduct of research, and also working with partner organizations in India and Australia to do sort of VALE type. I believe many of you may be familiar with the VALE course. So this is to design research protocols in cancer research. Take that sort of VALE model and apply it to India and the Asia Pacific region, Credo in India and Accord in Australia. These are slightly different, however, in the topic of the research that's being done, whereas the VALE tends to be on drug development. Credo and Accord are more multimodality, and it's also looking at research where you're repurposing low-cost existing drugs to improve outcomes in resource-limited settings. So again, emphasizing the need for specific research for a resource-limited environment. ASCO, through its Conquer Cancer Foundation, provides research funding. We're one of the greatest, largest funders of cancer research specifically for low and middle income countries through our innovation grants, our fellowships, and YAs in global oncology. And then finally, in terms of research dissemination. So this is where I think one of the things that separates ASCO from a typical foundation, because then we're able to marry up that research funding those findings with the channels, the global channels that ASCO has to get that out into practice. So the JCO Global Oncology, our annual meeting, has a global health track. And most recently, our breakthrough meeting that we started in Thailand in 2019. So here is kind of a map of our activity last year. This year has been obviously affected by the pandemic, and I'll get into that. But just kind of, I'm not going to go through all these pins, but just kind of gives you a sense of the breadth and depth of ASCO's activity globally. Just kind of pick out a few things. So the dark blue pins are the innovation grants. So these are investigators in these countries discovering novel cancer control solutions for a lower resource or lower middle resource setting. The purple pins are, I mentioned the quality measures. These are COPE certified practices. So these are practices that have been certified to be providing the same level of care as the COPE certified practices in the United States. And again, and we're looking to move this more into lower resource settings. But we're hopeful that this can serve as a benchmark for quality care delivery in a range of practice settings. Okay, so you may be thinking that all sounds great, but in terms of a pandemic, how are you able to do some of these international programs? And I'm going to dive into that now. Before I talk about the impact of the pandemic on ASCO, of course, we need to pause here for a moment and just acknowledge, as you all know better than I, really the impact of cancer, of the pandemic on cancer care delivery. And in the Q&A, I'd be really interested to hear what Yale's experience has been in this regard. I just wanted to flag this really interesting study, again, published in the JCO Global Oncology, 350 cancer centers in about 50 countries, snapshot of the impact of the pandemic. So this was what I'll call the first wave, because now we're in a second wave. The table is just sort of gives you a sense, but I encourage you to take a look at it. And the impact of the pandemic on cancer care in low and middle income countries can also be the subject for another talk. And you know, ASCO has its registry. There are other COVID registries in other countries. I think the impact on delayed diagnosis and ultimately patient outcomes in cancer as a result of the pandemic is yet to be seen. And that will be important data to see. Turning to the impact of the pandemic on ASCO, well, first and foremost, of course, the annual meeting, we had to shift what is a massive scientific meeting in Chicago and move it all online, basically in a matter of about 6 to 8 weeks. It was a massive undertaking. Those of you who did participate, I'd be really interested to hear what you thought. We were quite pleased with it. The number of attendees were comparable to the in-person. In terms of countries, we actually got an even greater participation globally, and actually much greater, not surprisingly, greater participation from countries where participation in the in-person would be more challenging. So just easier for clinicians to access the insights that are presented at the annual meeting this year. So that was very helpful and very informative. And just actually a final point there, I think we learned a lot from this experience. The benefits of having that kind of online experience says to us that having some kind of hybrid experience, even after a pandemic, in a post-pandemic environment, will likely have some online or hybrid components to the annual meeting going forward. It was extremely helpful. From the start of the pandemic, as some of you may know, ASCO created a resource library for care during the pandemic. And I just want to highlight this because this was another example of innovation where ASCO really crowdsourced from its membership what are the challenges for the practitioner in the pandemic environment, and then furthermore, crowdsource the solutions and work with its membership to arrive at the solutions to those and answers to those questions, and then compiled it all together into this repository of resources. So it really kind of shifted, I think, our relationship in a way with our membership in a very direct way, and I think offers lessons for how we can engage our global membership going forward. So we took the insights from that repository, worked with our international members to kind of globalize the guidance and the insights, translated the report into 7 languages and put it out and to inform practice around the world. Like everyone else, ASCO has been organizing webinars. But I think for a society like ASCO that, again, has this global membership, the webinar series was really an incredible experience because, again, we were able to tap into very early on in the pandemic when it was really, when Italy and Spain and Asia were really being affected in a drastic way by the pandemic. We were able to tap into our members in those countries and host webinars, connect them with our members in other countries, understand what they were going through, what they were learning on the ground, and incorporate that into lessons for our members and constituents in other countries. So it was a very helpful way for us to connect our membership and learn from them. And these were recorded, so if you're interested, they're on ASCO's YouTube channel. All of those programs I mentioned earlier on, we're shifting them over to virtual frameworks. I won't get into this in detail, happy to get into in the Q&A if there's interest. So some of you may be familiar with Project ECHOS, which is sort of a teleeducation platform. So we're doing Project ECHOS with colleagues around the world, case discussions. We're even doing some guidelines adaptation, which is an example here, working with colleagues in other countries around the world and other collaborative projects. So what were some of the lessons learned? So again, I think ASCO has learned quite a bit in terms of its meetings and how does it help to educate its membership and the cancer community. There are ways that we can supplement the in-person education with the online and virtual elements. We've discovered ways that we can scale up our global impact through e-volunteering and exploring strategies around that. And we've discovered ways that we can engage our members in a much more direct way to glean from them their insights and put that into practice. In terms of care delivery and research, I think ASCO's members and practices learned quite a bit from this experience. Just a preview of coming attractions, ASCO formed a task force called the Road to Recovery Task Force that outlined some very specific lessons learned from the pandemic. So efficiencies and innovations that can be applied to practice going forward. And these recommendations will be published, I believe, soon in JCO. So keep an eye out for that. In the meantime, turning again to JCO Global Oncology, I'd recommend that you take a look at this really interesting paper by Saini and colleagues, emphasizing some of these same points, ways that we can reimagine global oncology clinical trials, so the increased use of technology, opportunities to so-called cut the clutter, make the regulations and paperwork simplified, driving speedier approvals, and always keeping the patient in the center. So looking beyond the pandemic and future directions in global oncology. So here, I actually just want to step back in time a little bit to 2016, which is, so ASCO around this time, the board of directors of ASCO convened a task force called the Global Oncology Leadership Task Force, charged with helping ASCO to chart the next round of expansion for ASCO globally and ASCO's role in global oncology. One of the recommendations of this task force was the following, as you can see on this slide, that there's an opportunity for ASCO to transition global oncology from what has been a largely informal field to a formal field with a strong research component and recognize value to oncology training and the practice of oncology. So ASCO, being ASCO, then formed another task force to look at this question in detail. And this task force was chaired by Julie Graylow with the following members. And actually, we just published the recommendations of this task force, again, on JCO Global Oncology. I'd recommend that you take a look at it. But I'll go through some of the highlights with you today. So first, we had to define global oncology. We felt the need to have a little more specificity around this. Generally, it's seen as the oncology as applied to global health, but the task force felt the need to have some more definition around this. I'll pause here to let you read the definition. So a fairly comprehensive approach, and really speaks to the importance of global oncology as not just solely the practice of oncology in a resource limited setting, but looking at it holistically across the board. And so I think that holistic approach is really important. So just kind of go through some of the recommendations here. The first was that, and by the way, the ASCO Board of Directors has approved these recommendations, and ASCO is working to implement these, and I can provide some highlights or updates on that. So first and foremost, the importance of raising awareness of global oncology and the importance of or opportunities for incorporating global oncology in HemOnc and MedOnc training programs. And I'd be really interested to hear what Yale's experience and has been in this regard, and what opportunities, if any, you provide your trainees in global programs. Because ASCO actually, in talking with ACGME, identified, I think, more opportunities for innovation around the training programs than was previously understood. So there's an opportunity there. And then beyond HemOnc, working with other special societies, ASTRO and so forth, to identify opportunities for to incorporate global oncology in the training of other subspecialties. So global oncology competencies. So what's required to do global oncology? So ASCO will actually be coming out with a companion publication, hopefully in soon in the coming year, on specifically what global oncology competencies are. So some of them are in a traditional sort of global health framework or global health training. And then there are aspects to oncology in the practice of oncology in a resource limited setting that one would not normally receive as part of their standard oncology training. And so we outline those competencies as ASCO perceives them. And then there's a role for ASCO in creating a repository of these training opportunities and resources as the field develops as a formal academic discipline. So turning then to research and practice, we need to advocate for the importance of global oncology research. And I just want to pause here a moment to make a point that's I think is particularly important. I think we have sort of we sometimes creates sort of a false distinction between addressing disparities in access to care issues in the United States and disparities in access to care issues outside the United States. So one we sort of think as sort of domestic issues, and then the rest are sort of global health issues. I think there is a huge opportunity for us to break down that barrier. So the global oncology research can directly inform the insights and the improvements to care that we potentially can make in the United States. So for example, an innovation around access to care that's developed in Mumbai or in another setting outside the United States can provide insights to improve access to care in the rural United States or other disadvantaged areas in populations. So we need to sort of think about the role for this kind of research domestically as well, and make that case. So we need to find bridge funding. So there is funding for getting started in global oncology research, but we need to support investigators through the continued part of their profession and keep them on the path. Through JCO Global Oncology and other channels, we've been disseminating global oncology research, but are there opportunities for us to, for example, present more scientific research at the ASCO annual meeting on global oncology, and how can we do that? And then we need to promote equitable relationships between the researchers in higher resource settings and the investigators in the lower resource settings, making sure that we're learning from and listening to investigators in those lower resource settings, because that's the whole point, isn't it? And making sure that that's an equitable relationship. And then in terms of professional development, see this a role for ASCO as a professional home for the global oncology community. So for the next generation, helping to connect them with networking opportunities, to be mentored from the pioneers in global oncology, and being a repository for career opportunities as they emerge in global oncology. As I said, there are many pioneers in this field, and the role for a professional society like ASCO to recognize these leaders, celebrate them, and again, support the emergence of this as a respected and recognized field. And then some overall recommendations, integrating global oncology into all those international programs that I highlighted previously, the importance of partnering with oncology societies and other organizations, including the NCI Center for Global Health, and the Fogarty Center. So in the time remaining, I hope I'm still doing okay with time. Just a few sort of personal reflections on
yes, you've got 10 minutes, Doug.
Oh, perfect.
So
okay, great. Perfect. So these are sort of more my personal reflections, don't necessarily reflect ASCO's formal position. But as was mentioned in the introduction, and thanks again for that very kind introduction, I came to ASCO not from the cancer community. I didn't have a professional background in cancer, certainly not oncology. And I was new to the medical association field. So I came from the standard sort of global health, international NGO world. So with that sort of outsider's perspective, it really kind of actually came clear to me quite quickly what a huge environment, vibrant and surprisingly for me, surprisingly vibrant community the Oncology Society community is. So not just ASCO, of course, ASH, ASTRO, ACR, pathology societies, ASCP, and others doing great work. International societies with PSYOP in pediatrics, PSYOG in geriatric oncology, and of course, all the national societies in countries around the world. And so when I look at this community, I see a huge opportunity for societies like ASCO to support global cancer control and global health. You know, when I was working with the Red Cross and we would start a program in another country, there are significant investments that an international NGO needs to make to do programs. You know, you need to set up the field office, hire staff, consultants, lease jeeps, you know, all that sort of thing. These international NGOs would give their right arm for the assets that societies potentially can bring to bear to global health. So first and foremost, we have our members, the depth of the knowledge of our members and their experience, which is a huge asset. These members are in the field. So right now, as we speak, we have hundreds of ASCO members practicing oncology in low and middle income countries. This is their day-to-day. And the insights and experiences that they have from their practice is a huge asset as we think about how to improve the care in these settings. The network. So these members all have professional relationships, formal and informal, that we can tap into to improve, to deliver programs. Societies are always forward-looking, so a big research component, always looking at, well, what does the evidence say? So in our guidelines, in our presentations, in our publications, it's always forward-looking and building on the evidence. Societies have authority. It's the societies like ASCO, their opinion is respected and carries weight. And related to that, we have influence. So we have access to policymakers, either in the United States or our members in countries around the world often are in position to influence policymakers in their countries. So taken together, there is enormous potential, I think, for societies to have a positive impact in global oncology and global health generally. It may be because I have two teenagers at home, I sort of think of it this way, but I think the societies in global health are at a sort of an adolescent stage. I think we're just scratching the surface. We're growing internationally, starting to apply our strengths, but I think we can do more. Aware of the challenges of the world and figuring out what is the role for societies like ASCO to address these challenges. ASCO and other societies, we're not going to do it all. You know, we have our niche. You can see in the bottom right of the slide, our tagline, knowledge conquers cancer. Our focus is on knowledge and capacity building. How does that slot into the other components of global oncology and global health? And overall, I just think it's a very exciting time of promise and potential in that regard. What are the challenges to realizing this? So in global health, as many of you know, you have to strengthen the health systems. You have to take a systems approach. And quite honestly, this is not always emphasized. And so we need to be mindful of that and try to approach it from a systems perspective. Implementation science, we always need more data and evidence on how to, what programs have impact, how do we know that they have impact, and incorporate that into the actions that we take. Our volunteers are outstanding. We couldn't do what we do without our volunteers, but they're volunteers, they're dedicated, but they need to be supported and their work needs to be formalized in a way. And our in-country members have multiple demands on their time, and that's always a challenge. So this kind of, in my mind, points again to the need to formalize global oncology. In doing that, we need to learn from other global health disciplines and experiences. So just to summarize the take-home messages, I hope I've helped everyone to sort of informed you about the rising global cancer burden, and that this has been, this rise is part of an overall shift to NCDs in low and middle income countries. ASCO is not just an organization, but a community that can be harnessed to address these challenges. The pandemic, while a global catastrophe, of course, has forced innovations that can have a lasting and potentially positive impact on this response. And it's critical to formalize global oncology in terms of training, mentorship, research, and practice. And societies like ASCO can have a major role in global health. So I'd like to thank the International Affairs Committee, in particular the chair of our committee, Clarissa Mathias of Brazil, and all of our members you can see from all over the world, and just a fantastic group of volunteers. The International Affairs staff, a small team, but I call them the special forces because we're small but high impact. And then finally, if all through all this, some of you have been thinking, well, this global health sounds like a lot like the restoration of a vintage car. Well, you'd be spot on, because like global health, you need a range of stakeholders to do this work, including your dog, Jasmine. And sometimes you need to do things differently. So in this case, installing the engine from underneath the car as opposed to from above. And you always have to be thinking about the next generation. In this case, my daughter, Taylor, and teaching her how to work on cars. So with that, happy to welcome any questions and answer any questions and look forward to the discussion. Thanks.
Thanks, Doug, for this incredible overview of all the work that ASCO is doing. I was not aware of the breadth and scope of it all, and really thought of it. I know many of my Harvard colleagues go to the conference in Chicago, and they've presented a lot of the epidemiologic research and so forth. So I hadn't been aware of the extent of your work in global oncology. I'm wondering, just to start off, we have a few other questions as well. Like the NCI has picked up on global oncology being very important, as Charlie mentioned, I think early on. And I'm wondering, was that just like parallel worlds, or is it a result of sort of some of the advocacy that your department has been doing? And, you know, how are you working with NCI, and where do you see NCI going with this?
Yeah, no, NCI, they've been terrific partners. We work very closely together. I really think, Donna, so this has really emerged, and one of the reasons I started with the UN meeting, I really think over the past 10 or 15 years, there has been an emerging consensus and focus on this issue. I think a rising awareness of the rise of cancer in low and middle income countries. And so I think the NCI Center was an outgrowth of that rising awareness, and it's just sort of been the zeitgeist, if you will, that we're all working on this. Yeah.
Yeah, great. Now Anise Chagpar has asked, can you speak to how institutions and LMICs, low and middle income countries, can become QOPI certified? I don't even know what that means. So maybe you can explain that to those of us who don't know, and then maybe address the question.
Yeah, so this is the COPI program. So this is the quality measurement program, and so there is a legal component to it. So you know, there isn't time to get into it, but our lawyers need to assess the patient data privacy laws in each country to see whether we can do COPI in those countries. But assuming that the legal analysis has been done in a particular country where a center is, I'd be very happy to connect them with our clinical affairs staff and start looking at that.
Great. And Melinda Irwin said very positively. She loves the ASCO Global Oncology definition. I do as well. And she's wondering if others agree with the focus on disparities and differences and the focus on implementation science and policy. So that's sort of a question to others, I guess, not necessarily you. Presumably you agree with that.
Yeah, I mean, I do. Of course, the volunteers developed the definition. I'm just staff, but I think you do have to look at it holistically for the reasons I tried to share in my talk.
Yeah. Okay. Well, we're a minute over the hour, so I think it might make sense to thank you again very much.
Okay.
Pleasure to meet you and for you to reconnect with some of your old friends. We appreciate you virtually coming and giving this presentation today.
Well, thanks again, and I apologize that I took so much time. I meant to leave more time for discussion, but you know, if there are any unanswered questions, you have my email. Please send them my way. I'd be very happy to answer any that I can. And look forward to hearing more about the work of Yale and global oncology.
Mhm. Great. Okay, so thank you, Doug, and thank you all.
Thank you.
Bye-bye.
Great. Thank you.